Okay, so like I was saying, for muscles, the way that you remember, okay, first off, for muscles, you have to memorize origin, insertion, and innervation. When it comes to action, you can remember that a muscle is going to have an origin and an insertion, and the action is pulling the insertion towards the origin. Okay, so obviously he started with these four muscles: your pec major, your pec minor, your subclavius, and your serratus anterior. And so now we're going to actually look at them in picture form. So first off, here's your pec major. And you can see how in this picture it has it labeled. I believe this is from Moore, so you can find this in your Moore textbook, how there's three different heads of pec major, how you have your clavicular head, your sternocostal head, and your abdominal part. And notice how like these are all of this long strip here is the origin of pec major versus the insertion is over here, this tuberosity on your humerus. So our action is going to be taking, like it's going to be pulling this insertion towards these different origins. So you can see how, because you have these three different parts of the muscle and you're pulling this one origin, excuse me, this one insertion towards the origin, you can have the action be like the clavicular part taking precedence, and you're pulling more upward versus the sternocostal part taking more precedence and you're turning more inward. Or the abdominal part taking more precedence and you're turning inward but also down. So that's how, when it came to like actions, I was not good at memorizing the list of actions for things, but I was good at visualizing and saying, okay, so pec major has these three major parts where they have the origin. They all insert on this area. So to get the action, I'm going to be pulling either towards this clavicular part or the sternocostal part or the abdominal part. So what kind of action is that? And also, I would recommend that when you're doing this, when you're thinking about actions, origins, insertions, you should do it on your body as well. Like, this is anatomy. We all have a body that we're working with. So it's well within your right, when you're trying to visualize and understand something, like practice it on your body. In tests, you can even, like, you might even see this like with your neighbor. It's like they might be motioning, like doing the motions themselves. That's fine. Like, that's perfectly fine for you to do, to try and visualize and remember what's happening when it comes to the actions of a muscle. So that's pec major. For pec minor, oh, somebody threw something in the chat. So, oh, sure. So for pec minor, you can see that its origins are actually on the ribs themselves. Your pec minor is deep to your pec major, and the insertion is on the coracoid process here. So obviously, if you're doing that, that means that that coracoid process, that part of your scapula, is going to be pulled down towards your ribs. Here's your subclavius muscle, which the name pretty much tells you. Subclavius, sub meaning below, clavius, the clavicle. So subclavius muscle underneath the clavicle. And then your serratus anterior. So for serratus anterior, you have that serrated part in the name, serratus anterior. So that can make you think of the fact that this muscle has like, it looks like a serrated knife because it has all of these pieces. And you can see how it has attachment to all of these different ribs. I also am a person, when it came to learning about muscles, I liked these pictures where it was color coded, where you have, for this particular one, the origins are in pink and the insertions are in blue. That was another way that helped me visualize and remember like where muscles started versus where their insertion was. Okay, so these are more muscles of the shoulder region where he did not give you the chart for them, but unfortunately you have to know all of these too. So we'll like talk about some of them, and these are specifically, it has some of your sits as your sits muscles and Yeah, it just has all of them in there. Does he give you a chart? Okay, he does not give you any chart. Okay, we'll just talk about a little bit. So looking here, you can see this is, your shoulder. Here's your humerus. Here's your scapula. And obviously, here's your glenohumeral joint. So this is super important for when it comes to shoulder injuries. So I'm sure he's probably mentioned this, but I'll go over it anyway. How you have your sits muscles, SITS, that are incredibly important when it comes to shoulder stability and shoulder injuries. And you want to memorize those muscles of your rotator cuff. Everybody remember sits, SITS, and it's for, there we go, supraspinatus, infraspinatus, teres minor, not major, teres minor. They love to throw both of those muscles in, but it's teres minor that's a part of the rotator cuff muscles. And then subscapularis, right here. So you can see how there's this big muscle that's hugging the inside of your scapula here. That's subscapularis. So supraspinatus, infraspinatus, teres minor, and subscapularis are the 4 muscles of your rotator cuff. Remember those. Also, you want to remember that supraspinatus, this one that's coming across the top and then attaching, that's the muscle that's most commonly injured in rotator cuff injuries. So let's see, other muscles that are featured on this picture. Well, teres major is like cut off here, so we'll talk about that one later, most likely. Hopefully there's a better picture of it later. Another important muscle when it comes to movement of your shoulder is your deltoid muscle. Just like your pec major, your deltoid muscle has 3 muscle bellies, and you can see how you have the clavicular part, the middle part, and then what's the name of this one? The posterior part is how I learned it, but it could also be called the spinal part of the deltoid. So these 3 areas of this muscle on your shoulder, and it makes it so that you can have really good range of motion when lifting your arm. So important thing to note when it comes to movement of your arm, your supraspinatus muscle is the muscle that actually initiates movement of the arm when you're abducting, and it goes from 0 to 15 degrees, as opposed to your deltoid muscle, which picks up at 15 degrees and goes to, I believe it's either 90 or 120. I have it on my slides. I'll look it up later. But it does most of the work from 15 going up to like 120 or 90. I'll look it up. But then from there, your scapula gets rotated so that the arm can go all the way up in the air. But the important point is that supraspinatus is the one that's initiating that abduction from 0 to 15. So there's probably going to be a question that you get somewhere where the patient can't initiate abduction, but then when the doctor holds the arm out to about 20 degrees, they're able to lift their arm from there. That's a telltale sign that supraspinatus has been injured. Another one would be something like the doctor holds the arm and then the patient is told to slowly lower it. And then once they get to about 15 degrees, it just drops. That's another way to tell that supraspinatus has been injured. So let's see, what other muscles do we have here? Okay, another muscle over here, you can see on the right, this is your Latissimus Dorsi. Your Latissimus Dorsi is this big, broad muscle. This muscle specifically comes into effect when you are lifting the body up. So when you're trying to do pull-ups on a pull-up bar, that's your Latissimus Dorsi. So the action, like the Latissimus Dorsi, is pulling your body up towards that bar. You can see how it has its insertion on the humerus here versus this broad origin. So bringing that towards that, or that towards that, excuse me. Okay, So the fascia of the axilla and the pectoral regions. I know that Dr. Austin likes the clavipectoral fascia. So you're going to want to know this picture pretty well and understand how it's surrounding the muscles here. So you can see that clavipectoral in the name, so it's going to involve the clavicle and the pectoral region. It extends between your coracoid process, the clavicle, and the thoracic wall. It envelops your subclavius muscle, which you can see right here. See, here's your clavicle, here's your subclavius muscle, as well as pec minor, which you can see right here. It includes your costocoracoid ligament, which is right here. Your costocoracoid membrane, or actually, excuse me, that was the membrane. Does it show the ligament on this picture? It does not show the ligament in this picture. And the suspensory ligament of the axilla. Unfortunately, I'm not seeing the nerves that pierce through it on this picture. That's another thing that Dr. Austin has in previous years quizzed people on, is the nerves that pierce through the clavipectoral fascia. I think that's in my review PowerPoint. So what'll end up happening after this, like you guys are gonna get this video, but I'll also send my review PowerPoints along with it just to help y'all with studying. So your axillary fascia forms the floor of your axilla, and then your axillary sheet encloses the axillary vessels in the brachial plexus. Oh, sure. Okay. All right, so the axilla. The axilla is basically your armpit. And the reason why we care about the axilla is it is a place where a lot of things are running through. You have major nerves and major blood vessels all going through this area. So you can think of it as like this pyramid shape. It's between your upper thoracic wall and the arm. So this pyramid in here. And it has a lot of boundaries. And unfortunately, they want you to know them. So medially, you have the upper ribs and their muscles. Laterally, you have the intertubercular groove of the humerus, which you can see here. Posteriorly, you have Subscapularis, teres major, and Latissimus Dorsi muscles, which I believe you can see over here. Yep, Latissimus Dorsi, and then teres major, and then Subscapularis. Anteriorly, it's bordered by pec major and pec minor and the clavipectoral fascia, which we already talked about. The base of it is your axillary fascia and skin, and the apex is the interval between your clavicle, your first rib, and the upper border of the scapula. It's all up in here. So like I said, we care about the axilla because there's a lot of things running through it. You have your brachial plexus, you have your axillary artery and vein, you have lymph nodes. I've never heard of the axillary tail before, but these three here are the big things that I learned when I took anatomy. Brachial plexus, axillary artery and vein, and lymph nodes. So brachial plexus, okay. Yeah, this is when I'm gonna switch. Actually, hold on. Intro. Okay, so when it comes to the brachial plexus, and like I said, these are my review slides. I'm gonna send them to y'all, you'll be fine. When it comes to the brachial plexus, yes, it does look complicated. Yes, it can be difficult, but also, yes, you all can do this. Everyone before you has had to memorize this. You will learn it. So let's break down the brachial plexus step by step to help you learn it. And you're going to need to memorize it. And you're going to need to memorize it such that if they give you a picture or like a drawing of the brachial plexus, and they give you a scenario where a person has injured something, so they have weakness of something, you need to be able to identify the nerve that is damaged just from a plain brachial plexus picture. So you pretty much need to know how to identify every nerve on a brachial plexus that's drawn out. So yeah, so let's go through this. So first thing is, everybody has their own mnemonics that they like to use when memorizing stuff. For memorizing the 5 parts of the brachial plexus, I liked to use read the darn cadaver book. So that breaks down into your roots, which the spinal roots of your brachial plexus are C5 to T1. And then trunks, where you have a superior, a middle, and an inferior trunk. The divisions, which are anterior and posterior, which are all in reference to the subclavian artery. So are they anterior to the subclavian artery or posterior to the subclavian artery? And we'll see the divisions in a little bit. The chords, which are lateral, posterior, and medial, and these are in reference to your axillary artery. And then finally, your terminal branches, and there are 5 of them. So your 5 terminal branches are your musculocutaneous nerve, your axillary nerve, your median nerve, your radial nerve, and your ulnar nerve. So if you look in Netter's, this is the brachial plexus that they have in Netter's. And normally, if it weren't COVID and if this weren't virtual, I would have us draw this out. So I do recommend that you draw out the brachial plexus and then create it as a quiz for yourself. When I did it, let's see, I know it's in here somewhere. There we go. So for me, when I was learning this, I drew this out with labels like this shown here on the front of a piece of paper. And then on the back, I had all of the labels with the answers so that I was able to just quiz myself by flipping that page back and forth to see, had I memorized this correctly? Since we can't draw it out, what we're gonna do is I'm gonna literally just like talk you through this. And I think you right now should pull out a piece of paper as we do this. If you don't want to do this, there is a really good video here that I provided the link for y'all, so you can click on this later, where there's this dude, his name is Dr. Preddy. It's on YouTube. He looks like a football player in scrubs. Having said that though, he breaks it down, makes it super simple for you when drawing it out. I have another Dr. Preddy video link later when it comes to learning innervations of like the arm and the forearm, but that's on another date. But yes, I like Dr. Preddy for like his upper limb stuff. So we're gonna go through it, but if you wanna listen to, or if you wanna watch him draw it out, you'll be able to go to this link later. Okay, so brachial plexus. So first you can see here are roots. So here's C5, C6, C7, C8, and T1. The first thing that I want you to notice when it comes to these roots is see how C5 and C6 join together, and C8 and T1 join together, but C7 does not. That's going to be the first thing when you're drawing your brachial plexus, when you're orienting yourself. C5 and C6 are going to come together here. C7 is just straight. C8 and T1 come together here. Now, you have a nerve coming off here, and a nerve coming off here, and a nerve, hold on, did I label that one? Not that one. Okay, so just these two. There are 2 nerves that you need to know specifically in relation that for the brachial plexus that come off of the roots. So this first one here, labeled number 1, that's your dorsal scapula. So your dorsal scapular nerve right here. So when you're drawing your brachial plexus to study, you're going to want to have like one little nerve coming off right here for dorsal scapular. Next one is this guy right here. So you can see how it's taking fibers from C5, from C6, and from C7. So C5, C6, C7, labeled here number 2, that is your long thoracic nerve. So when you draw it, make sure you have your roots coming from C5, C6, C7, long thoracic nerve. Oh, and I need to mention this now too. You're gonna want to know the roots for these nerves because they can quiz you on that too. They can, unfortunately, give you a question where the patient has a weakness of some action. You know that it is related to the specific nerve that's damaged, but then they just give you a list of nerve roots and you have to pick which one is correct. So your dorsal scapula is just C5, but your long thoracic pulls from C5, C6, and C7. So those are the 2 nerves off of the roots that you got to learn. Okay, so moving down, we're now at the trunks. So you can see how now here's your superior trunk, your middle trunk, and your inferior trunk. So the next 2 nerves that you have to learn, they both come off of the superior trunk, which makes it a little bit easier. And because they both come off of the superior trunk, I believe they both have C5 and C6 as their roots. But then you'll see here, so this number 3, that's your nerve to subclavius. Remember subclavius, that muscle that's underneath our clavicle. Versus number 4 here, that's your suprascapular. And we'll see later on, the suprascapular nerve has a specific path that it takes that you have to memorize because that's another question that they can ask you is the path that the nerve takes in relation to the suprascapular artery. So just a note, when it comes to anatomy, if things travel together, but they're like different, they'll often get the same name. So if you have a nerve, an artery, and a vein that are all traveling together in the same direction, they will often get the same name just with a modifier. So there is a suprascapular artery and a suprascapular nerve. That's completely normal. It happens quite often. So just be careful when you say suprascapular. Are you talking about the nerve? Are you talking about the artery? It can get tricky, so just be aware. Just like you're gonna have, there's a radial nerve and a radial artery, but also there's the radial bone. So yeah, anatomists try to like group things together when they're labeling and naming, which, you know, fundamentally does make sense, but can be confusing. So just be careful. So just to reiterate, here are the 2 nerves that you need to know from your 3 trunks. The superior trunk is the only one that has nerves coming off of it. And the 2 nerves that you need to know are nerve to subclavius and suprascapular nerve. When it comes to the divisions, no nerves, like no branches come off of the divisions, which is nice. So you don't have to memorize anything from there. You just have to, when you're drawing it, you know that there's this X here, and then there's this like one part here. A thing to help you understand better how you're going to associate these nerve roots with these nerves that come further off, that branch off, is that nerve roots, when they're coming, they can only go forwards. They can't go backwards. So see how C5 and C6 are both part of the superior trunk? Well, that means that everything forward of the superior trunk can have C5, C6 roots. And like C7, since it's coming like straight through, here's your middle trunk, it can go forward as well. But notice how like C5 cannot come back down this way and then go forward. Like that's not something that can happen. It can come down this way and go forward, but say it can't like come down and then go backwards. The nerve roots are always just going to go forward. So that's something that like Preddy will talk about in his video when he goes over it. But yeah, so the nerve fibers are just going to go forward when you're trying to figure out what nerve fibers are a part of these terminal branches. Okay, but yes, your divisions, nothing comes off of here. Just learn you're making an X and then a Y when you're drawing it. Okay, so now we're at the chords. The chords have a lot of little branches that you need to learn, but you can chunk them together when you learn them and it makes it easier. And once again, this is how I did it. So it helped me a lot. So first things first, notice how you have this branch coming off of here, your lateral cord, and then this branch coming off of here, your medial cord, and then you have this piece that connects them. Well, knowing that this branch is coming off of your lateral cord is helpful because this nerve is lateral pec nerve or lateral pectoral. This one coming off of your medial cord, number 6, is medial pectoral. And I didn't label it here, but I'm going to say it. Hopefully you guys remember this for later. This branch that connects the two of them, this branch is called the Ansa Pectoralis, A-N-S-A, Ansa Pectoralis. I know that Dr. Austin previously has talked and lectured about this in classes past, so I'm just going to mention it again, that this is the Ansa Pectoralis, A-N-S-A, that connects your lateral pec and your medial pec. So I group these two together in my brain, obviously, because they're pectoral nerves. So our next set, 7 and 8, I also group together. So they're both cutaneous nerves, but they go to different areas. So 7 is your medial brachial cutaneous versus 8 is your medial antebrachial cutaneous. So when you see antebrachial, think forearm versus brachial, just think arm. So antebrachial cutaneous is going to have cutaneous innervation more distal versus brachial cutaneous is going to have cutaneous innervation more proximal. So medial pec, medial brachial cutaneous, medial antebrachial cutaneous. And then now we have these 3 nerves grouped together here on our posterior cord. So these I chunk together because depending on which name you use, all of them have subscapular in the name. And this is also associated directionally as well. So number 9 is your upper subscapular. Number 11 is your lower subscapular. Number 10 in the middle is sometimes called middle subscapular, but most often though, it is called thoracodorsal. Oh, and I'll add an S in there because that's a typo. But yes, this is thoracodorsal, also known as middle subscapular. And then you have upper subscapular, which is more proximal, versus lower subscapular, which is more distal. So lots of nerves coming off of your cords here. You're going to need to be able to identify them just off of like a plain picture of your brachial plexus. Okay. And so now finally, our terminal branches. First one at the top is musculocutaneous. And this is coming off of your lateral cord. Next 2, I'm going to talk about together. You can see they're both coming off of your posterior cord. So radial is this thick one here, number 14, versus axillary is this thinner one here, number 13. Depending on the drawing that you see, axillary can come off above or it could come off below from radial, but you just need to know radial is going to be like the thicker one coming off of the posterior cord versus axillary is going to be the thinner one because axillary comes off and then it innervates your deltoid and I believe your teres, is it teres minor or teres major? I'll look it up. But it innervates your deltoid and a teres muscle and then does cutaneous innervation over the deltoid. versus radial is going to do innervation on the posterior aspect of your arm and your forearm, going all the way down to your hand. So it has way more nerves that, way more innervations, therefore it's going to be a thicker nerve. It's like doing more. Up, and I think there's somebody in the chat. Okay, what's up? Minor, thank you. So teres minor and deltoid. So radial, axillary. Our next terminal branch, so notice here, and this is how a lot of people will remember it, so it's helpful. Notice here how you create an M. Well, that's how people will remember the name of this nerve here, the meeting of your medial and lateral chords. It's your median nerve. Now, yes, I know this is annoying, but unfortunately, you have to memorize this. It's median with an N, median nerve, as opposed to the medial cord, as opposed to the middle trunk. Yes, it's annoying. Sorry, guys. It's the way that they named it. So median nerve, creating like it's the tip of your M in the middle is the median nerve. This is another, and I'll give you another heads up when it comes to like the drawings that they've done of brachial plexus that I've seen on quizzes and tests. So because this is like a joining at like the tip of the M, technically they can have the picture where this posterior cord drifts a little bit down and your radial and axillary nerve are on this side. That can be another way that they try and trip you up. So you just have to be able to trace the brachial plexus and see, okay, this is coming off of the lateral cord at the top, so musculocutaneous. Here's my posterior cord. So these have to be radial and axillary, and then the meeting of the lateral and the medial is your median. So this area can be down here, axillary can be coming off the other side. You just got to remember, you just got to know the picture and can translate it for yourself when you're looking at this during your test. And then finally, our last terminal branch here, number 16, this is ulnar nerve. So notice how ulnar nerve, there's no way for it to have nerve fibers coming from C5 and C6, or C7 for that matter, I believe. Yes, it can only get C8 and T1, and you can see that pretty plainly from this picture when you're tracing it. So going straight, you only have C8 and T1. Ulnar nerve was always the easiest for me to remember the nerve roots that it came off of, because C8 and T1 came here, and going forward, you can only get fibers that way. Versus like median and radial, I think had fibers from all 5 roots, or at least 4 of the 5 roots. So yeah. And then musculocutaneous was like C5, C6, and C7, I believe. But yeah, this is your brachial plexus. And like I said, when I was learning it, I would literally do this and just like quiz myself. All right, what's 5? What's 6? What's 2? And you just got to practice. You can do the flashcard form. Sometimes I would redraw it out from memory, like the brachial plexus from memory, along with like the little pieces coming off, and then label it and see if I was right. So this is something you just got to practice, folks. It sucks, but it's something that we've all had to do, and you can do it. Okay. So going back to Dr. Lobo's slides. Okay. So that was brachial plexus. Okay. Now, axillary artery. When it comes to axillary artery, how do I approach this? Actually, let me back out of his slides because he didn't really give you a run up to this, and I want to give you a little bit of a run up. When it comes to axillary artery, remember arteries are like continuations of each other. Like an artery just doesn't magically pop up. It's going to be a continuation from somewhere. Where is it? There we go. So we'll actually start with this one. So I like this schematic because it's obviously not to scale, but it gives you a rough idea of, oh, all of these arteries are connected and what's the flow that they take. So when we were learning the blood supply to the upper limb, we would start at the heart, because you have, the heart is pumping blood, and so you pump the blood out of the heart. So coming out of the left ventricle, you go through your aortic valve, then you go to the aortic arch. So the first branch off of your aortic arch for your right arm is your Brachiocephalic Trunk. Now, when you look at, oftentimes when they do pictures of arteries of the upper limb, they give you the right upper limb because it's only on the right side that you have this Brachiocephalic Trunk. On the left side, the left subclavian and the left common carotid come directly off of the aortic arch, as opposed to on the right side, you have the Brachiocephalic Trunk, and then it splits into the right common carotid and the right subclavian. So you do need to memorize that distinction, that coming off of your aortic arch on the right side, the first branch is your Brachiocephalic Trunk, but then for your left upper limb, your left common carotid and your left subclavian come directly off of the aortic arch. So we have our Brachiocephalic Trunk, we have our right subclavian, and then after our right subclavian, we then have our right axillary artery. So these are all just continuations. So your heart is down here. Here, like right underneath the manubrium here, is your Brachiocephalic Trunk, and then it bifurcated, which is just the fancy term for it split into two, into your right common carotid and your right subclavian. So your right subclavian, your axillary artery, your brachial artery. See how these are just one long tube, but anatomists have named it for different areas because you have different branches coming off and you have different muscles and it's going over some but under some. So they picked areas where they said, okay, at this point, the name is going to change so we can differentiate between the subclavian artery versus the axillary artery. So the name change happens at the lateral margin of your first rib. Now, I don't know if you guys have learned this or not, but you can't actually feel your first rib because your clavicle's in the way. But when you're looking at the body for dissection, the change in name of that artery from subclavian to axillary artery is at the lateral margin of your first rib. So now that we are at the axillary artery, so we start talking about what Dr. Lobo, I'm assuming, lectured you guys about. The axillary artery is divided into three parts, and it's all in relation to your pec minor muscle. So you can see pec minor here. The first part is before you get to pec minor. The second part is deep to pec minor, so it's like underneath the muscle. And then the third part is after, is when you've gone past pec minor. So first part, second part, third part. Another helpful thing when it comes to this is that when we chunk the information about what's in, what are the branches for the axillary artery, thankfully you can chunk it in such a way that the first part has one thing, the second part has two things, and I'm putting two in quote bunnies here because you'll see in just a second, and then the third part has three things. And once again, that's in quote bunnies, but it just kind of works. So we're looking at our axillary artery. We're looking at the first part. The one branch that comes off of the first part of your axillary artery, you can see here, is your superior thoracic artery. For the second part of your axillary artery, so we say it has two things. Well, unfortunately, one of those things is the Thyrocervical Trunk. When you hear trunk in the name of an artery, know that that means it is about to branch off itself. So the trunk is this area here before it branches again. So it's like, I'm going to be a big branch that's then going to have smaller branches. So my name is going to be something trunk. So this is your thyrocervical trunk. And then your thyrocervical trunk has its own 4 branches that you need to memorize, unfortunately. Most people use the acronym DCAP, because it has a deltoid branch, a clavicular branch, and a acromial branch, and a pectoral branch, so DCAP. But those are the 4 branches off of your thyrocervical trunk. The next thing that comes off of the second part of your axillary artery is your lateral thoracic artery. So just a heads up, for those of you who noticed, there is a superior thoracic artery, there is a lateral thoracic artery, and then depending on how deep into the weeds Dr. Lobo and Dr. Austin get when it comes to it, there's other thoracic arteries that they may or may not ask you to memorize, because like internal thoracic is something coming off of subclavian, but I don't know if they've taught you subclavian artery yet. And then there's highest thoracic, which is another branch that has to do with subclavian. But since Dr. Lobo didn't have subclavian in that particular lecture, we're just not going to talk about that. I just want to mention that there's going to be multiple thoracic arteries. So just be specific in which one you're talking about. Is it internal thoracic in the first part of axillary artery, or is it lateral thoracic in the second part of the axillary artery? Okay. So now we're on to the third part of the axillary artery. The first branch coming off of the third part of the axillary artery is your subscapular artery. Now, it's important to note that subscapular artery then is going to have circumflex scapular artery branch off and go to the posterior aspect of your scapula. So know that circumflex scapular artery branches off of subscapular artery. And then also the thoracodorsal artery also comes off of subscapular artery. And then the second and third branches coming off of the third part of your axillary artery are easier to remember because you have anterior circumflex humeral and posterior circumflex humeral artery. So notice how those names are telling you where they're going and what they're surrounding and what they're doing. So anterior circumflex artery is the artery that runs anterior, and circumflex like surrounds the humeral. So anterior circumflex humeral artery. It's running forward, it's circling around this anterior aspect of your humerus. Versus posterior circumflex humeral artery. It's running posterior, it's circling around the posterior aspect of your humerus. Now, note, and it's shown here in this picture, these two arteries actually anastomose. So, and anastomosis is the scientific term for arteries that come together and share blood flow. So they're forming this ring around your humerus to create blood flow all the way around it. So anterior and posterior circumflex humeral arteries in the third part of your axillary artery. Okay. Okay. And then, yep, all the axillary stuff. And then axillary vein, which you can see, oh, where are you? So when it came to the veins of the upper limb, the ones that we needed to know about that were important were your basilic, cephalic, axillary, and median cubital, which you can see how your basilic is here, your cephalic is here, and then your axillary is here. So notice how your basilic vein is running into your axillary vein, but your cephalic vein is gonna like insert into your axillary vein. And then axillary later, like right here, is going to combine with your external jugular to create your subclavian, and then that's further than, oh yeah, and he shows it here. Well, he says it here, how you drain into your subclavian vein. Okay. So axillary lymph nodes, you're going to want to learn these specifically because they're going to have a relation to the spread of breast cancer. So thankfully, once again, the names are telling you where they are. So you have your lateral axillary nodes versus your posterior axillary nodes versus your anterior axillary nodes versus your central, and then your apical. So think apical apex at the top. So lateral, posterior, anterior, central, and then apical lymph nodes. And now here you can see, here's the breast tissue, and then these lines of lymph vessels going to those lymph nodes that we talked about. So one of the annoying things that you'll see in anatomy is that things often have multiple names. So your lateral lymph nodes are also called your humeral lymph nodes because remember our humerus is here and it's lateral to the chest wall. So lateral lymph nodes, humeral lymph nodes. Versus your posterior lymph nodes also are known as your subscapular lymph nodes. So subscapular because it's posterior because it's posterior to like the chest wall or on the posterior aspect of the chest wall. So posterior lymph nodes, subscapular lymph nodes. Versus your anterior lymph nodes are also called your pectoral lymph nodes because pectorals, they're on the anterior aspect of the chest wall. So anterior or pectoral lymph nodes. Apical is still apical because it's still at the top. And then also shown here is your supraclavicular lymph nodes. So supra means above, and then clavicular means clavicle. So supraclavicular, the lymph nodes above your clavicle. So this is a good schematic here when you're just trying to think about the relationship of, okay, how is this lymph fluid draining? So your humeral draining into your central, your subscapular draining into your central, your pectoral draining into your central. So central taking lymph from all three of those, and then central going into apical, and then apical draining into your supraclavicular nodes. Okay. So circulation around your scapula. So we already went through the branches of your axillary artery, but you can see here in this picture that like your scapula, it's this weird funky looking bone. It has stuff jutting out. Like it's weird and it's odd, but it's super cool because it helps us move our arm better and move our shoulder around. So our bodies have created this circulation around it. Different arteries and anastomosing so that like the muscles and the bone can get all of their nutrients. So you have to learn the blood vessels that are helping to create the circulation around your scapula. So you can see how on this medial aspect of your scapula, you have your dorsal scapular artery. Well, dorsal scapular actually was one of the branches off of subclavian, which I don't know if he went over subclavian artery, but you can see dorsal scapula on this medial aspect. So dorsal scapular artery on the medial aspect of the scapula. You also have, and I mentioned it before, how you have your circumflex scapular artery. So you can see here how the circumflex scapular has come around and is now giving blood supply to this posterior aspect of your scapula. So dorsal scapular, circumflex scapular. You can see here how suprascapular is on the superior aspect of the scapula, and it's giving blood supply to the superior aspect. So coming in, and this is another one that's off of like one of the branches off of your subclavian artery. So suprascapular coming in and aiding with the circulation around the scapula. And then where is the other one? So there's dorsal, there's circumflex, Suprascapular. And then I know that so when we did this, it was all like teacher preference as to what was the fourth artery that you could learn when it came to the anastomosis around the scapula. Because sometimes it would just be like these anastomoses from the intercostal arteries, because they do give blood supply, but sometimes the professor wants you to know that, sometimes not. And then what was the other one? Oh, I can't remember off the top of my head. But yes, so you can see here, so anastomotic branches from your intercostal arteries giving blood supply, along with dorsal scapular, suprascapular, and circumflex scapular, all giving blood supply to the scapula. Okay, so I'm actually gonna stop here because it's 3:56. I got most of the way through here. What was left? Wing scapula, lymph node stuff, and okay, acknowledgements. All right, so wing scapula, this comes up, I'll talk about this and then we'll stop. Wing scapula comes up because it's good fodder for questions. So you can see how you can very clearly see the scapula coming off of this person. The way that you test for wing scapula is the patient, you'll have them stand up with their shirt off and you ask them to push their arms against a wall. So normally you have muscles that are holding your scapula to the chest wall so that you don't have this protrusion coming out. However, when you have damage to the nerves, obviously the muscles then aren't going to work, so you then can't hold the scapula to the chest wall. So when you have damage to that long thoracic nerve, remember from our brachial plexus that it came off of the roots, C5, C6, C7, you then will have paralysis of your serratus anterior. So that serratus anterior normally it helps hold the scapula to the posterior chest wall, but when it's not innervated anymore, obviously you can't do that. So the mnemonic that we learned for this particular clinical correlation was C5, C6, C7, wings to heaven. So just reminding you, wing scapula. So C5, C6, C7 is the roots to long thoracic. So when you damage long thoracic, you paralyze serratus anterior and you end up with wing scapula. Okay. So since it is 3:58, I am going to stop recording